My name is Blake Cady. I'm a surgical oncologist. I now work at Cambridge Hospital in the breast center at Cambridge Hospital, which is focused largely on breast cancer patients. And I'm, as I say, a surgical oncologist, so I've worked in patients with surgical problems and cancer for all of my career. Well, I can best talk about the effect of screening with my own career. When I was in training in the mid-'60s at Memorial Hospital, all we saw were advanced cancers that were palpable, because that's the only way to detect them, and a radical mastectomy was the standard operation. Then mammography was introduced first in the early 70s, and then the reaction against it. Then in the mid-80s, there was a big upsurge in mammographic screening. And since that time, the size of breast cancer has decreased progressively from what it used to be as 2.5 inches in diameter down to about a half an inch, a little more than a half an inch in diameter currently. It used to be that when I was in training, 2/3 of all women had positive lymph nodes. Now it's less than 30%, usually less than 25%, because we're seeing disease at such an earlier phase because of mammographic screening. And this decrease in size and decrease in node metastases has been a progressive thing ever since mammography was introduced. I recently worked in Rhode Island for about 10 years, and there the median diameter, that is the mid-range diameter of all breast cancer in the entire state, is about 1.5 centimeters, a little more than half an inch. And the mortality rate has dropped progressively beginning in 1990. And in Rhode Island, the mortality rate has declined 44% in the state which has the #1 incidence of screening mammography. We've just recently done studies in Massachusetts, #3 state in the country with screening incidence, and the mortality has declined 41% in Massachusetts. So every country or every state that has introduced mammographic screening has seen a decline in the mortality beginning about 4 to 5, 6 years after mammography is introduced, introducing the concept that this is all due to mammographic screening. It's not due to systemic treatment, because that was going on before and continues, but the point at which the mortality in breast cancer started to decline is always about 5 years after the onset of mammographic screening. So the data is overwhelming that the decreasing mortality is related to screening. Well, our hypothesis when we did a study was, if we look at women rather than when they begin the trial, we looked at women who actually died of breast cancer, and we looked at 461 women from the Partners Healthcare group in Boston who we could prove died of breast cancer. That is, they proved that they had breast cancer, we proved that they had metastatic disease, and we proved that they actually died of the disease. In that group of 461 women, 25% of the deaths occurred in the 80% of women who were in screening programs, and 75% of the deaths occurred in the 20% of women who were not in screening programs. So if you translate that into what will happen to women diagnosed in 2009, you'll see that women who were in regular screening programs, followed for 12.5 years, which was our follow-up period, that if they're in regular screening programs, the mortality rate will be less than 5%, 4.7%. If they're not in screening programs, then they all appear with palpable cancers like they did before screening began, and there the death rate is 56%. Just the same rate it was back in the late 1960s before we began screening. And that makes sense, because these women are all appearing with palpable cancers. So it's just another way of looking at the data, indicating that the major way for women to avoid death from breast cancer is to participate in regular mammogram screening. Well, we were looking at all women with breast cancer. Now, the women that die of breast cancer tend to be younger, because they tend to be seen before screening, or disease in younger women tends to be more aggressive. So the median age of all the women at Partners was relatively young at 55, because they have a young, educated, higher socioeconomic clientele here. The women who die of breast cancer, the median age was 50, but the women who have palpable cancers, the median age was about 48. So these are women who, in every age group, the women who die are predominantly among the group of women not being screened. In other words, even in the 60s and the 70s in our study, women who die of breast cancer largely are in the group that are not being screened. Now, there are reasons for women not being screened: low socioeconomic condition, disadvantaged minorities, non-English speakers. The poor and disadvantaged make up the largest group of people who are not being regularly screened. So there are other aspects of why women are not being screened, but the data we show coincides completely with the screening trials, which is that if women are in regular screening programs, their death rate is very, very low compared to women who are not being screened. Well, in our study, and I think in the randomized controlled trials, it clearly indicates that if women are in screening programs, their mortality rate is quite low. One of the things that people forget is the randomized trials hypothesis was if women are offered screening, you'll reduce mortality. But in women who are offered screening, only about 2/3 actually get it. And in the control groups not offered screening, about 1/3 of women get screening anyway. So the results in the randomized trial, which are already statistically significant, probably understate the actual advantage of screening by women actually getting screening by at least 50%, if not 100%. And in studies where women are actually screened, you can see that the mortality rate is decreased by over 50%, which is the kind of thing we're seeing in the state of Rhode Island, where in 16 years now, the mortality rate has declined by 44%. So we're already seeing in an entire state that's heavily screened, the mortality rate will decrease by much more than 50% by 2015.